Good afternoon, everyone. Thank you all for joining us today for our webinar discussing oral chemotherapy and colorectal cancer. My name is Zach Getty, and I am the Patient Education Program Manager here at Fight Colorectal Cancer. Fight Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States, providing balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. Before we get started with the actual webinar today, I do have a couple of housekeeping items, so please bear with me while I go through this. We will have some time at the end of the webinar specifically devoted for questions from people viewing, but please feel free to use the Q&A panel on the right side of the screen to ask any questions that come up along the way. I'll be sure to get to those as we can, and I will be sure to address as many of them as possible. We will have the recording of this webinar available on our website in the next few days after we're done with this. As a registrant, you will automatically receive a link to the webinar recording in your email as soon as it is available. And last but not least, please feel free to tweet along with us. You can use the hashtag CRCwebinar. A little self-plug for Fight Colorectal Cancer. Please remember to stop by our website at fightcrc.org to check out all of our patient and caregiver resources. This includes your Guide in the Fight meetups, which are an online space to meet with other patients and caregivers, which are held 4 times a month with another one of our partners, Carol Matika, and our free Community of Champions app, where you can connect with other people in the colorectal cancer community. And we also have a whole suite of print and digital educational resources that are free to request for physical copies and also free to download digital copies as well. So with all of that out of the way, I would like to, I do have a disclaimer here. The information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you may be ill, please see a doctor immediately. In an emergency, please call 911 or go to the nearest emergency room. Fight Colorectal Cancer will never recommend or endorse any specific physicians, products, or treatments for any conditions. Now, with that out of the way, I'd like to introduce our panelists for today. We have Dr. Van Morris, Associate Professor in the Department of Gastrointestinal Medical Oncology, Division of Cancer Medicine, University of Texas, MD Anderson Cancer Center in Houston, Texas. We have Phuong Gallagher, our Fight CRC Research Advocacy Training and Support Manager and Stage 4 rectal cancer survivor, and Rissa Dodson, Stage 3 colon cancer survivor. I'd like to thank all 3 of you so much for taking the time out of your schedules to be with us today. I'm going to hand it off to Dr. Morris, Phuong, and Rissa so they can introduce themselves just a little bit more thoroughly, and then we will get into the actual meat of the webinar. And I'm going to stop sharing my screen as it's just going to be conversational in tone today.
Thanks. My name is Van Morris. I am a medical oncology physician at MD Anderson in Houston. And the majority of my practice at MD Anderson is treating patients with colorectal cancer. So we use lots of chemotherapy, and there's a lot of questions that always come up with our patients and their families when talking about the various drugs we use. So I'm very, happy to be here today, and always happy to work with Fight CRC, with whom we often refer patients to, as we know, just to be a great support for patients and their families. So thank you for having me, and I'm happy to share the panel today with Rissa and Phuong.
Hi, everybody. I'm Phuong Gallagher. It's so nice to be here. I also appreciate being here with Dr. Morris and with Rissa. I am a stage 4, 16-year survivor now. I am in active treatment, which I think is a bit unusual in perspective. In that time, I've really seen the arc and change in treatment from 16 years ago. And so that certainly has piqued my interest in research and keeping up with that. One of the options being discussed certainly for us is oral chemo. So I'm excited to get into this with all you.
Hi, I am Rissa Dodson, and echoing everyone else's sentiments, I am definitely happy to be here and honored that I was asked to participate. I am a stage 3 colorectal cancer survivor. In September, it'll be 7 years. And so thank you so much for having me. I appreciate it.
Absolutely. We're thrilled all of you volunteered your time to participate, and we really appreciate it very quite seriously. Thank you very much. So with that, I have just some questions just to kind of get things started here about oral chemotherapy and cancer treatment in general. So Dr. Morris, what drugs are available via oral chemotherapy, and are all oral medications available for cancer treatment considered chemotherapy?
Yeah, I mean, this is a great question, and certainly kind of as Phuong kind of referenced, compared to say the landscape of options 16 years ago, we're seeing, more and more treatment options become available for patients with colorectal cancer. Now, I think it's important to keep that where we've seen really, for the most part, the newest additions happen, are in patients with stage 4 disease, with metastatic colorectal cancer, and this is where many of the new oral options have become available. I think it's important for patients and their families to realize that when we're talking about oral or even IV treatment for cancer, that they don't always have to be chemotherapy, right? So chemotherapy, just in general, the way I like to think of it is kind of a class of drugs which work via different mechanisms, but work in different ways to target cells which are dividing more rapidly. And because that's, kind of how cancer works, that's why chemotherapy has been, effective and around probably longer than any other class of agents in oncology. As cancer treatments have evolved, over the past decade or so, we're seeing more and more, as I mentioned, options become available. And these include things called targeted therapies, which, unlike chemotherapy, which again just is targeting which is going against cells which are dividing quickly, I kind of think of targeted therapies as more kind of like smart bombs, where they go directly to that spot you want to hit. And I often explain that to patients is if you think about sometimes genes and mutations as kind of on switches, like a light switch when turned on can trigger a tumor to grow and divide. A targeted therapy will go to that light switch, hopefully and turn that off, and hopefully shut down that cancer cell from doing what it's otherwise trying to do. And there have been some targeted therapies in select populations of patients, which have become available over the past several years. Encorafenib is one targeted therapy that's not technically chemotherapy, but it's an oral pill that we can use in our patients with BRAF mutated colorectal cancer. There are other targeted therapies as well, which have been around for some years, that maybe we won't have time for today to discuss, but these, one drug is called regorafenib, or Stivarga is a commercial name your doctor may have spoken to you about. That is an oral pill as well, but it's not a traditional chemo drug. And regorafenib has several targets that it goes after. And then more recently, we had data that was presented about a year ago now, looking at another oral drug like regorafenib called fruquintinib. And this may be a regimen or a drug that you've heard about, which also showed that it helped patients with stage 4 colon cancer. Fruquintinib is also not a chemotherapy drug, yet it is another oral agent for colorectal cancer. And I think we can expect probably the FDA to make that, an available option for the, in probably the next 6 months is my guess, but don't hold me to that. So those are some of the kind of non-chemo oral drugs we talk about. But traditionally, when we're talking about oral chemotherapy, historically, that's been a drug called capecitabine, which you may have also read or heard about as also called Xeloda. And that's one that's been around for a while now. More recently, there's been another oral chemotherapy drug. Its long name is trifluridine and tipiracil, but more commonly referred to for ease of both patients and oncologists alike, just calling it Lonsurf by its commercial name. And that's shown, great promise as an oral chemotherapy drug. And we'll have time to talk about that later. So I'm going to stop right now and just let the other panelists have a chance to weigh in here too about these drugs.
Yeah, so I was actually on capecitabine. So that was the one that was most familiar to me. And that really came much later in my my treatment plan and experience here. It's, it really didn't come up until within the last 5 years, to even be an option. So that was definitely something that we grabbed hold of. And I think that there are definitely pros and cons to the IV versions of what's available to us versus the chemo or oral agents. Personally, for me, I think that side effects wise, it was easier for me to go through the oral agents. However, I have to keep in mind that those are different drugs from what I was getting in the IV form as well. So, with capecitabine, for me, it was more of a maintenance drug than a treatment, go kill the bad cells kind of drug.
I started Xeloda the first day I had radiation. So my first radiation treatment and Xeloda, those were that's where I started. So I took Xeloda for the 10 months that I was in treatment. And then I had IV chemo. I had IV chemo starting in May. So from May until September, it was both the IV and the pills, the oral chemotherapy.
And that's important to note too, Rissa, because in addition to the capecitabine, I had the infusion of Avastin every few weeks with the restart of the cycle as well.
Right.
Interesting.
Yeah,
So
I'm sorry, go ahead.
Well, I was just going to say that actually hits on a question that I had is would oral and IV chemotherapy ever be administered at the same time? So it seems like, yeah.
I want to step back for just a second though, and just make sure that we're kind of all on the same page here. So, when a patient is diagnosed, let's just say for the first time, and they come in with a diagnosis of stage 4 cancer, they may talk to their oncologist about being on, multiple medications at the same time. And sometimes they hear about the pump, which goes through the port and then is connected for about 48 hours, about 2 days. And the drug that we give through the pump is a drug called 5-fluorouracil, or 5-FU. It's another way to that's more commonly called. And so capecitabine or Xeloda, this oral chemotherapy that we're all kind of referencing, works against the cancer in the same exact way. So in terms of what the cancer sees, whether it's the pump, which goes for 48 hours, or it's the oral pill, the cancer is seeing the same thing, and these drugs are equivalently doing the same thing to the cancer. And the way that kind of works is that it's a drug that was kind of chemically engineered to trick the DNA to use it as a building block. And kind of when that happens, that impairs the ability for when the cells divide to make correct copies of their DNA. And when that happens, the cells kind of get overwhelmed. They say the DNA isn't copying like it wants to. I'm just going to kill this cell off. Could I cut my losses, kill the cell off? So it kills the cancer cells, which are replicating by kind of tricking the DNA. So we can do that either with the IV route or by the oral chemo route. And but at the end of the day, infusional 5-FU, the pump works, against the cancer kind of equivalently to the oral Xeloda capecitabine drug that Rissa and Phuong were mentioning.
And just to clarify, Zach, when I mentioned that I was talking about infusions at the beginning of the cycles, that Avastin is actually a biologic, so it's not a chemotherapy agent, but it works in conjunction with.
Okay, thank you. And so I've actually had a question pop up that's pretty topical about this. Are the side effects from oral chemo the same as traditional intravenous chemo, or are they different? Experience different tolerability, all of that?
So maybe I can kind of start answering that question, then I can ask kind of Rissa and Phuong, like just if you guys would kind of talk about what your personal experiences were. But I would say that yes, the side effects tend to be can be a little bit different. The oral capecitabine drug can be associated with increased risk and rates of things called hand-foot syndrome. And specifically what we mean by that is the hands and the feet, the surfaces of the hands and the feet, so the palms and the soles can kind of become red, irritated, and sometimes that skin can kind of slough off, which obviously is very uncomfortable for patients. And we can see that happen a little bit higher with the oral form of the drug than sometimes when the IV is administered. Another side effect, which can be more common when the oral version is given, is sometimes you can get what we call stomatitis, which is just kind of irritation around the mouth and kind of these what we call mucosal areas of the body. Sometimes that can show up as kind of some ulcers, some ulceration, which can be uncomfortable. These are things which can be treated, very easily. Well, can be treated in most cases easily for improvement of symptoms by oncologists once they know about it, but that's a little bit higher risk as well. And then diarrhea is something that can also be a little bit higher rates than for people with when they're given the oral form than perhaps the IV form of that. There's a couple of other kind of considerations I always think about. Somebody who because the routes are different, even though again, kind of going back to this idea that the cancer is seeing the same thing, the route that they take to get to the cancer is different when it's given IV versus oral, right? If you think about it, with an oral pill, we have to, swallow the pill, and it has to digest through our GI system and then make its way eventually to the bloodstream. So with the oral pill, sometimes the kidney function is it becomes more relevant in patients who have impaired kidney function when they're starting their treatment are at higher risk of toxicity if the doses are not adjusted. So one of the things we have to really be mindful about is if we're going to give the oral capecitabine chemotherapy, what is the patient's kidney function? Because if it's reduced or impaired, we have to watch that very closely, because those patients are a lot higher risk for kind of even more toxicity from treatment. And there's also kind of more drug interactions between the oral form and other drugs that a person might be taking. One example of this is the blood thinner Coumadin, which by and large, most people don't take anymore because there are new and kind of, I would say, better blood thinners than that. But just the risk for complications between the capecitabine and Coumadin can be very high. But also for patients who have had a history of seizure and maybe on a drug, for example, like Dilantin, the way that the capecitabine chemotherapy is metabolized, that can make it harder for the body to get rid and process the Dilantin, and patients can get increased toxicity and side effects from that medication because they're on the capecitabine that they wouldn't be on otherwise. So we have to be mindful of what other drugs patients are on when they're getting this oral chemotherapy pill. So Rissa and Phuong, kind of what were your experiences and side effects with the capecitabine when you were on it?
Yeah, when I was taking, I definitely had the hand and foot sensitivity. Like I felt like I could feel like every fiber in the rug. I felt like I could feel, every single rock, everything. I just felt, I felt that. But mostly it was exhaustion, to be completely honest. And I'm not sure if it was because I was doing both radiation and the oral chemotherapy at the same time, but those were the two that really that I took notice of right away.
Yeah, and I did have the beginnings of, just some sensitivity like you did, Risa. But, I really took heart what my oncologist said at the beginning, just let us know what your side effects are. Don't feel like anything's too small to mention. And so I was hyper vigilant. And like Dr. Morris said, we can dial things in. And as patients, I think sometimes we don't realize that our doses can and should be adjusted depending on what is happening. And so as soon as I started mentioning, okay, I'm seeing this, I'm feeling this, it was, oh, okay. So I think we dropped like 1 or 2 days from my chemo cycle rather than lowering the dose on a day-by-day basis. We just dropped 1 or 2 days from my cycle, and all of a sudden it was easy as can be for me. I felt like I hardly had any side effects. I didn't feel much different than my normal off weeks. So I think that is really important as patients, that we don't have the feeling of, oh, I don't want to be a bother. I don't want to, or I want to get the max dose so that I can, blast this into oblivion. And that's not always the best case. So it's always really best to talk to your oncologist, share what's happening. Don't be afraid to do that. If you're one that wants to get max dose, that's something to voice and discuss, because then you can talk through the treatment plan of why this might help you stay on for a longer period, which would be more beneficial rather than a short and hard fast hit.
Right. Initially, I was very like, oh, they told me this, and I didn't want to voice, little things like, is this supposed to be happening? Is this? But then I finally did, and was, open enough to say, like, this doesn't feel right, or I don't like this, or can we do this? So yeah, that's very important as well, like that you were saying, Phuong, just to make sure you say it.
Yeah, I often tell my patients, just to kind of comment on that, is the one thing I don't like are surprises. So I don't want to hear about the toxicity of your chemo 3 weeks later when you come for your visit. I would much rather you call me or call my team, a week into it and say, hey, this is what's going on. And then so that we can address that promptly. We can address the symptoms as they're happening, because that could, potentially, like, let's just say, I mean, we know that one of the side effects, as I kind of mentioned, and we were talking about, can be diarrhea as well. I don't want my patient becoming like severely dehydrated that they have to go into the hospital because they're, in kidney failure. I need to know about that now, and I can act proactively about that, and my team can. But if I don't know about that and I find out about it because I hear they're, in the ER right now, then we might start having to delay treatments, which then like doesn't, kind of gets us behind, in the schedule on things. So always being proactive. And I always say, I don't want surprises. You can tell me anything, just not a surprise, because it's better to be proactive. And like they said, we can always, with your next round, dial back if we need to. Alternatively, if a patient comes in and we feel like, hey, they've recovered from their surgery, but they're not 100% yet, maybe for this first dose, we can dial back on the dose a little. It's kind of, instead of jumping in the deep end, kind of wade into the water, and kind of go up and see how they do with time. So these are all options. And again, it's a discussion, between the patient, their family, caregivers, and the providers.
Excellent. So it sounds like if patients are experiencing toxicity, any extreme side effects, the time to call their physician is now and not wait. Specifically, besides hand-foot syndrome, stomatitis, diarrhea, are there any other things that patients should be looking out for that would signal toxicity, that maybe they need a dose adjustment or just need to call their physician?
Yeah, I mean, I think that relative to the infusional form as well, sometimes we see that the blood counts can, take a little bit more of a hit from the chemotherapy, where patients' white blood cell counts, which when low can increase the risk of infection. Their platelets which if low can increase the risk of bleeding, and their red blood cell levels, which if low can cause anemia, that this can happen as well. So this is why your doctor may always talk about, ordering what we call a CBC, or a complete blood count, before every kind of cycle of therapy, to make sure that these numbers are doing okay. I will say, as an oncologist, far and away, the most common question I get, and 100% of the time, it is preference with, and I always laugh at it because it's not, but the patients will say, I don't mean to sound vain, ... And I was like, I know what question is coming next, but am I going to lose my hair? And I hear this from men and women alike. But usually with these drugs, I tell people we would not expect, a person to lose their hair because of these oral chemotherapy drugs. Patients who know their bodies, own bodies better than anybody, may notice that they're having a little bit of hair thinning or hair loss, but usually not to the extent that if, you were walking down the aisle at the grocery and somebody you didn't know walked past you, they would be able to look at you and say, oh, that person must be on chemotherapy. We don't typically see that degree of hair loss with these drugs like we do with other drugs in oncology and even in colorectal cancer, like irinotecan being one of them. So we don't expect to see hair loss or hair thinning. On occasion, one of the interesting things about the the infusional 5-FU, but also the oral version, is that especially with the infusional 5-fluorouracil, by the time it gets to the tumor, the body and the liver have already metabolized out about 85% of the drug. So what ends up kind of sticking around in the system once it's made it, the IV form has made its way through its liver, is a fraction of what, was initially administered to the person. In a handful of patients, and in a minority of patients, they may have something that's called DPD deficiency. And what DPD is, it's an acronym for an enzyme, which is the enzyme that breaks down, this 85% or so of the chemotherapy. If a person lacks that, then what happens is they don't metabolize all of the medicine that's getting ingested out, and what their body is seeing is a much higher dose of the drug than the doctor or the patient had planned or expected. And this happens, again, in only a small fraction of patients, but when that happens, you can get really severe blood count. This can really severely affect the blood counts. It can really cause really, really bad diarrhea as well. And that can cause complete hair loss. So when a patient comes in and has kind of this out of proportion diarrhea, just, inexplicable diarrhea, severe hair loss, severely affects their blood counts, my suspicion for them having this DPD deficiency is going to go way high. This is something that we can test for to confirm that, and we would typically reduce the dose of the oral chemotherapy drug, accordingly.
Thank you. So, if a patient views the idea of oral chemotherapy as being easier to manage, I can take it at home, I don't need to come in for an infusion, I don't need to wear a pump, is that something that they can request from their physician, or is that decision made strictly on their presentation, on their disease state, on their medical situation?
Maybe I'll start with Rissa and Phuong and kind of see what their experience and what their conversations were with their doctors, and I can kind of circle back with my thoughts on that too. But I'll let you guys, I'll turn it over to you guys.
My oncologist said that the protocol was typically, radiation in combination with the oral and the IV chemotherapy. So that was the protocol, and that's what I did. So, all the information was laid out for me. So that's just, I just followed that.
Early on, I didn't even have a choice. It wasn't an option. It wasn't until later that we talked about maintenance chemo, and that's when oral chemo became a discussion point as a, as an alternative. And it, a same thing, we just had a conversation and it was what made sense for me at the time. So I think that's what it comes down to, really.
I think we're always willing to have, as doctors, this discussion with patients. I think it depends on the indication and what's happening with that person and their stage of treatment for colorectal cancer. So, one of the things that Rissa talked about was, she was receiving radiation and was given the oral chemotherapy pill with that. So I think when it comes for patients who are getting, those 5.5, 6 weeks of radiation, we know that the oral form of capecitabine works just as well in combination and with the radiation as the IV form. The IV form, though, would require that those patients be hooked up to a pump that goes around the clock Monday to Friday throughout those 5.5, 6 weeks. That also would require a PICC line or a port. So we can tell patients, they're probably going to still have to have the port for the combination chemotherapy thereafter. But patients will just say, if I can get away with not having to be hooked up to something for, 5 days a week for 5.5, 6 weeks, let me just try the pill. And as so I would say the vast majority of cases, we would use the pill form in combination with radiation. Now, let's imagine a situation where, or not imagine, let's consider a situation where a person comes to see their doctor because they've just gone to surgery. They had colon cancer, they went to surgery, and they were found to have stage 3 colon cancer. When oncologists look at, at stage 3 colon cancer now, we look at the pathology report to see how big that tumor was, how many lymph nodes were involved, and we kind of divide it into a lower risk stage 3 and a higher risk stage 3. And we know that for patients with the lower risk type of stage 3 colon cancer, that 3 months of chemotherapy is equivalent to 6 months in terms of it working to prevent the cancer from coming back. Yet, as you would expect, the shorter amount of time that people are on chemotherapy, the fewer long-term side effects that they have. So I think the field and most oncologists, would recommend 3 months of chemotherapy for patients with stage 3 colon cancer. The interesting thing about that is that's only true if you use the oral form of the chemotherapy. So we use the Xeloda with the capecitabine with the oxaliplatin. You can do 3 months of chemotherapy with that. But if the patient says, I don't want the oral form, or if there's a reason they can't tolerate the oral form, then we have to go to 6 months of therapy. So in a situation like that, if a patient had stage 3, like a low risk stage 3 colon cancer, and they said, I want 3 months of chemotherapy, as an oncologist, I would feel that it's medically inappropriate to recommend the IV form. They would have, if we're going to do 3 months, we have to do it with the oral form of capecitabine, not the IV form. So that's an indication in which, as an oncologist, I would say, I think it would be to your detriment if we did just 3 months of the infusional. So that's one indication in which the situation matters and how you give it IV or orally. Another situation is in patients with stage 4 colon cancer. Sorry, my light. Okay, it's back on. Patients with stage 4 colon cancer, for the most part, get usually two chemotherapy drugs as part of their treatment with for stage 4 disease. That is typically the 5-FU with oxaliplatin, and that's called FOLFOX. So the FOLF is the kind of 5-FU part of that, and then the ox is the oxaliplatin. And then, or they can get treatment with 5-FU and irinotecan, and that's called FOLFIRI. Alternatively, if you substitute out the infusional 5-FU with the oral, we would call it, so that would be capecitabine with oxalate. That's called CAPOX. And then capecitabine with irinotecan is called CAPIRI. So there's different ways that you can administer that. So we know that when we're using oxaliplatin, we can use that the infusional 5-FU FOLFOX is equal to Kbox. It doesn't really matter in terms of fighting the cancer, whether you go with the IV form or the oral form. However, multiple trials have shown that if you apply the same logic applied to irinotecan isn't true at all. So you would say, okay, if I can do oral or IV with oxaliplatin, I must be able to do oral or IV if I want to do the irinotecan as well. But very interestingly, a European study showed that when you take irinotecan and use the oral form, that patients their survival outcomes are not as good as if you do the infusional form with irinotecan. It was kind of a curious finding. And so a second trial that was done in the United States looked at the same question, and they actually had to stop that trial early because what they saw was that there were more participants who were dying because of the treatment with the oral form and irinotecan. So we do not, I can on one hand in 8 years count the number of cases that I've used oral capecitabine with irinotecan because not only is it associated with shortened survival for patients, but severe toxicity, including severe nausea, vomiting, diarrhea, dehydration, and even death. And in those very rare cases, it was because the patient said, I cannot stand the sound and the feeling of a pump and just the effect on me. I can't do that. And so it was on a very selected case-by-case patient. But I would just say that the oral and IV forms of 5-FU are not interchangeable in the treatment of stage 4 disease when considering what other chemo drug you're partnering it with.
Interesting. Thank you very much. So in a situation where somebody leaves your office with a prescription for capecitabine oral 5-FU, what does the process look like for them to actually get that medication? Is it just as simple as going to their local chain pharmacy, or do they need to seek out something special?
So it's a little bit more difficult than getting your your blood pressure pill that you get from the pharmacy just right down the street from you. So I mean, typically the hospitals or maybe the pharmacies that your oncologist are contracted with will have direct access to those. So at a place like MD Anderson, where I work, patients can just go down to our pharmacy without even having to go outside and have that prescription filled for them. But in the majority of cases, we have to work with the company's insurance and through a contracted specialty pharmacy. And by and large, there's really not difficulty in getting these drugs approved. They are approved by the FDA, but oftentimes those will be mailed to the patients by a specialty pharmacy. So it's a little bit more work, I would say, for the providers and maybe for the patients and their families, but yeah, not through the same pharmacists. Rissa and Phuong, was that kind of how your experience was?
It was a challenge to get started typically. I think that this is where it comes up where patients are like, I want to get started. I want to go right away so that we can start, I feel like I'm doing something rather than just sitting around. And then you have to wait because it does have to get approved by insurance. And, your doctor may want to start you this week, but it's going to take an additional X period for insurance to get that pushed through. So sometimes you have to, use your provider's resources to have to then call and work through the insurance piece. And then once you get approved, then you have to go register with the specialty pharmacy. Then you have to go through all the bureaucratic stuff. And I think that was one of the biggest challenges for me, because I had to start and then I stopped for a period and then I started up again. And each time that you start and stop, you're going through a similar process. Granted, the second time through, I was already registered with the specialty pharmacy. And like I go to a local CVS. Well, CVS has a specialty pharmacy, so it's the same overall company. It's just a different division, so everything's separate. But then yes, it gets mailed to me. Like once you get in there and it gets started, I found that it was pretty easy. But it was just that okay, let's get it going already feeling at the beginning.
I didn't have any of that experience. I went to my oncologist. She called the pharmacy, but I mean, granted, it was right there at the hospital, so I didn't have to go through any of that. Thank goodness. And just I would get my refills when I would go in for my IV chemo treatments. But other than that, I would just go and just pick it up whenever I was, whenever it ran out, just call it in and just pick it up. So that was the easiest part of the whole thing.
All right, so I've had quite a few questions actually coming in through the Q&A section. So I'm going to try to start addressing some of these. And some of these are fairly specific. So if you're unable to answer, Dr. Morris, that's understandable. But I'm going to start with a pretty straightforward one. Is there still a lack of production of Xeloda in the US market?
Yeah, this has been a major issue, not just for Xeloda, but for lots of drugs in oncology. And this is a great question. We have not had that issue at MD Anderson more recently, as opposed to say 6 months ago when this was a problem. So it does seem, I mean, just from our our experience, that this has not become something that we've had to kind of ration as we were having to do like 6 months ago. But that's very much due, and I want to give a shout out to Fight CRC and other patient advocacy groups for going to Congress and talking to our Congresswomen and congressmen to let them know that this is unacceptable. So it doesn't seem to have been an issue, although what's true on August 3rd could very well not be true on August 10th. So fingers crossed.
Let's see here. I have a specific, what would you recommend for someone with stage 4C colon cancer who's BRAF positive and MSI high?
Well, so sorry, they're BRAF V600E positive and MSI high CRC. Well, so I think that, based on the Keynote trial, which looked at patients with newly diagnosed metastatic MSI high metastatic colorectal cancer, what we saw in that was that immunotherapy was a more effective and less toxic option than systemic chemotherapy was. So as this is a talk about oral chemotherapy, I would definitely recommend pembrolizumab over the use of a combination like KBOX or other cytotoxic regimens. There are other trials which are looking at immunotherapy with BRAF targeted approaches as well, which somebody could talk to their oncologist about. But I would recommend immunotherapy in general over oral chemotherapy or IV chemotherapy.
Thank you. Another one specifically, as somebody states they're currently in watch and wait with their cancer. What type of chemo is used typically if the cancer returns? And it's pretty broad, I know, but.
Yeah, so just to kind of step back for a second. So watch and wait is a term that we use for patients who are treated with, kind of earlier stage non-metastatic rectal cancer. And so basically kind of how we would, let's just say that a person came to my institution now with a new diagnosis of like, let's say stage 3 rectal cancer at kind of the very end of the rectum. Oftentimes these patients are going to be treated with upfront chemoradiation, kind of as Rissa had detailed with her experience, and then followed by several months of chemotherapy. In the past, all patients would go to surgery, but there's about 20% of patients who, with that approach, the cancer may go away completely, depending on what study you look at. And maybe these patients don't require surgery and, a colostomy. So these patients, we watch them without going to surgery, and then we wait to see what happens. And as long as the cancer doesn't come back, then we're able just to continue to keep a close eye without any further treatment. So I think the question was, what do we treat for watch and wait? I mean, because it's a surveillance approach where we're just watching very closely, we don't treat with anything. If their cancer comes back, then I think it's, where is it coming back? If it's, because these patients are being watched closely, if it's, locally in the rectal area, I mean, those patients then may, need surgery. If they're going, say if the cancer comes back, but it's, in the liver or the lungs or another part of their body, then we're talking about, probably some chemotherapy up front. But again, that may depend on the specific subtype of colon cancer that they have. And, that may be kind of adjusted accordingly a little bit.
I've got two questions about hand-foot syndrome. First one is, if you stop Xeloda, does the hand-foot syndrome resolve?
Yeah, it can get better, for sure. Moisturizers are really, really good for this, that you can get over the counter. But if the hand-foot syndrome does get better, we typically wait for it to get better, and then maybe start back at a reduced dose. Rissa and Phuong, what were y'all's experience with? I know you guys said that you had experienced the hand-foot syndrome. Is that what happened with you and your doctor?
Yeah, I reported mine pretty quickly, and so we did the dose adjustments immediately, and then everything pretty much resolved itself. One thing that I did notice too, though, Dr. Morris, was I had some neuropathy too, which I was kind of not expecting with oral chemo, but it was there, it was minor, and when we dose adjusted, it went away. So just was popped in my head. That was another one I did want to mention. But as far as the hand-foot syndrome goes, I know a lot of people have used products like Bag Balm is one of the popular ones. There's Utter Cream or something like that, Utterly Smooth, I think it's the name of it. Things like that. There's some that are like more heavy duty intensive moisturizers, slather it on, throw on some cotton gloves and socks, and just sleep overnight in it and let it marinate, I guess. And it seems to help.
Yeah, mine wasn't severe, but I did the same thing, used Aquaphor and cotton socks. And it seemed to just resolve, yeah.
I just want to say, there was at ASCO, which is again kind of the big cancer conference in the United States we have every June. There was a very interesting study presented this past year from researchers from India. And what they looked is in patients who were getting this oral capecitabine chemotherapy drug, they looked and they tried a topical agent called diclofenac, which is something I think you can get at like your over-the-counter pharmacy. And what they saw was that in about 75% of cases, there was, reduction in the extent of hand-foot syndrome that patients experienced because, from the capecitabine. So I think this was something that unjustly did not get the press that it deserved, but is something that really caught our attention at MD Anderson. And we've been working and engaging with our pharmacists directly to make sure that patients are aware about that, and our providers are too. So that was called the D-Torch study, but is something to think about as well. I thought was really a cool study. So that's one option to kind of help with hand-foot syndrome.
So you must have actually read that last question ahead of time, because that was exactly what they were asking. Is if you had a personal opinion about the results of that study and Voltaren gel and usage topically for HFS.
I didn't read it, but I'm glad we're thinking all alike here. Again, that's something that I think when you look at the risk are pretty low from that, but the opportunity for benefit are pretty high. So we love studies with great benefit and low risk to patients. So yeah, very favorable opinion.
Absolutely. Awesome. So I do want to be conscious of time. We've got about 10 minutes left. So if anybody has any additional questions, I'd love for them to pop them into the Q&A panel on your right. I have one more practical question about what would you advise a patient do if they, take a dose of oral chemotherapy and then vomit it?
I mean, I think, first of all, realizing kind of like what's going on with that, I would say stop. I wouldn't try to replace that. Like usually, the oral capecitabine drugs are given, twice a day in the morning and at night. So let's just say like, you take your capecitabine medicine at 8 o'clock in the morning, and at 10 o'clock you vomit and notice that some of the medicines came up. I would not at that time say, I'm going to go ahead and just retake that dose or take another pill, because you don't know how much of that was actually absorbed in your system. And then if you retake it, then we're talking about increased toxicity and things that patients, we don't want our patients to have to experience. So I would just say wait until your next one, that night, consider taking a nausea med, talking to your doctor, and then taking a nausea med beforehand, and maybe kind of retrying as long as you feel okay with that. But I would say, yeah, don't substitute it or replace it for that particular dose.
That exactly happened to me during one of my doses. And I remember just panic emailing my oncologist, what do I do? He's like, just relax, take an anti-nausea before the next one. Do not take another. So, yeah.
Excellent. And then, sorry, Rissa, do you have any experience with that personally?
No, it's the exact same thing.
So I actually do have a question directly for you, Rissa. I know you kind of have a story around your oral chemo regimen and when you took your last pill. Would you mind to share that with us while we're on here still?
Yeah, I don't mind at all. Yeah. I took my last chemotherapy in my last dose of 4 chemotherapy pills in a hotel room in Springfield, Missouri, on my first night of Fight CRC ambassador training. I was in the hotel room by myself. I popped the pills. There were no balloons. There was nothing. I just, okay, that's it. And I walked across the parking lot to the restaurant and was met by other ambassadors in the Fight CRC team with the cupcake and hugs and congratulations. It was my first introduction to Fight CRC.
Wow.
So, yeah. It was great. It was great.
So if anybody has any other questions of viewing right now, please feel free to type them up. I'm looking through the questions I had prepared, and I think most of them have actually been covered just through the course of the conversation here.
Yeah, I just wanted to talk for 1 minute just about another oral. We've talked really only about capecitabine. There is another drug, which just yesterday got approved by the FDA with Avastin for patients with metastatic colorectal cancer. That drug is called, again, trifluridine tapiracil. Also, you'll see it probably more commonly as Lonsurf, LONSURF. That's the commercial name. But that drug, the reason it got the FDA approval, it's been around for several years, but the FDA approval came in combining it with Avastin or bevacizumab for patients with previously treated metastatic colorectal cancer. And that is a drug that works a little bit differently than it is a chemotherapy drug that's given orally. It works a little bit differently than the capecitabine drug does. And it works despite the fact that patients may have had prior chemotherapy with FOLFIRI or FOLFOX or other capecitabine containing regimens. I was on the phone maybe 2 weeks ago. One of my best friends here in Houston, her aunt, who lives in another state, had been diagnosed several years ago with metastatic colorectal cancer. And she was telling me that her doctor had her on just the Lonsurf. And when I kind of probed a little more, there was no reason that the patient shouldn't have been on the bevacizumab. So when we're talking about oral chemotherapy drugs for patients with stage 4 disease, stage 4 colon cancer, it's important that patients, when they're talking to their doctor, if they recommend Lonsurf, they need to make sure that they're asking their doctors, if they should be getting bevacizumab or Avastin with that. And most cases, unless there's a reason not to give bevacizumab due to other medical conditions or concerned side effects, should be getting this, because I was actually quite shocked that the oncologist wasn't offering this. And so I think she may be on it now. But this was an FDA approval just yesterday. And I just wanted to say that make sure just to advocate that patients are advocating that they're getting that drug in combination with that. I think we're seeing some really exciting results with that. And that's really changed and helped a lot of my patients personally.
You said it had been approved, FDA approved, that usage yesterday. Has it been used off-label like that for some time, or?
Yeah, yes. So the medicine alone without any infusion has been available for several years and has very kind of limited activity and benefit as a single agent. But where I think we really have been seeing the meaningful benefit is when you combine that with the bevacizumab. So that's what the approval was for the combination. Because we had seen this in the kind of the phase 2 trial had been promising, we had been kind of doing this, and for the most part, insurance was approving it. But just yesterday we got the FDA approval. So really this should be the standard of care for when it's used.
Very exciting. Is there anything else in development that you're aware of that new in this oral chemo space, or is that a big one right now?
I think that given the signal that we're seeing with the LONSURF, kind of looking at it in different lines of treatment and possibly different combinations, those are all kind of going on in clinical trials. But yeah, I think that's something we'll kind of see. We did talk a little bit at the beginning about fruquintinib, which I'd predict we'll get an FDA approval later this year as another oral non-chemotherapy option for patients with stage 4 disease. And then there are other targeted therapies, which are looking promising for kind of subsets of folks with, or subsets of populations of patients with metastatic colorectal cancer.
Thank you. So I know we're getting close to time. I have no other more questions in the Q&A box. So I just want to take this opportunity to thank the three of you for taking time out of your day, Dr. Morris, Rissa, and Phuong. We really appreciate you volunteering your time and your expertise and your personal experiences to come and join us today. So thank you very much.
Thank you so much.
Pleasure to be here. Thank you.
Absolutely. I'd also like to thank our sponsor for this webinar, is Taiho Oncology. Thank you very much for that. And then I'd like to share Fight CRC's mission before we say goodbye to everyone. So Fight Colorectal Cancer. We fight to cure colorectal cancer and serve as relentless champions of hope for all affected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. To those of you that have joined us at home, thank you so much for participating. Thank you for the questions that you asked. Please keep an eye on your email that you registered with, and we will be sending you a link to this recording in the next couple of days as we get this up on our website. So thank you to everyone and have a great rest of your day. Thanks so much.